represented in all kinds of ways. And so I have decided to look back on my own medical story, especially because it started, from Achimota school. And then to sort of comment on the intercepts between convey that my understanding of our healthcare issues is not as a world consultant or global expert, but it's just as a doctor who has worked in this country and continues to dream of better things for the future. I've also chosen my medical story as the template for my observations, because I think that sometimes when we look back over the trajectory of our lives, we can sort of connect dots that we never noticed before. So here goes. I still have an essay that I wrote in class 3 when I was in New Hope School, Kolebu. It was about my dream to be a doctor. And today I'm living that dream that I had all those years ago. At the time, I dreamt only for myself. But at that time, you can't think about the ecosystem that you need to become a doctor or to maintain an expert practice. And I think the society knows that, but we seldom think about what it takes for the doctor to be relevant, to be efficient, or even to be creative, and to do the special thing that we do in society. And this evening, as we talk about this ecosystem, I also want to talk about the process. And like I said, malaria, measles, touch and care over those nights when I was shivering with fevers and all that still underlines my ethos today as a doctor. I think that ultimately medicine works because doctors care. Seen doctors that, as an ill person, I did not want to see. And I knew the difference, even as a class 3, class 4 pupil. It was also a new hope that I discovered the joy of reading for pleasure. Because the headmistress introduced a reading hour during the day where books were brought in boxes for the children to unpack. And very soon, I was looking well beyond the box of books to where they came from. And this library in Central Park. And I had friends. Immerse ourselves into worlds of books and know for a short period until the library would close at 12:30. We would read, and then we would come back to our own worlds. Once we got into the to the administration, it's very interesting for somebody coming from Mamprobi Kolebu to Achimota School. It's a very imposing drive. And those first days were paradise. I met people who would become my brothers and sisters for life. And, we learned the song that said, school, and we were brothers and sisters. And that was it. This was our family. This was our new family. We spent 3 blissful days settling down in Achimota School, and then getting ourselves acquainted with this town. Had its own post office, police station, hospital, community swimming pool. Yeah. Then the rest of the school came back. And we were brought back to earth crushingly. Real school had started in earnest. I was a wreck in Achimota School in my first year. The school I dreamt about was not the experience I had. I could not organize myself well enough. I was called a confused boy a few times. I was walking the hallowed walls of this great school, but in dread of bullying, who was going to call one small boy. I was missing home, struggling with the food. Somebody said something looked like fish. And when it was time to sleep, I had nightmares of Obami chasing me to go under his bed. One day, all this came to a head because I was sitting in class, stressed, hungry, disorganized, and fainted. And for a few minutes, I went unconscious. I woke up at the Achimota School, at the Achimota Hospital. And, well, I may not have slept well, I may have been stressed, but whatever it was, I ended up with the neurosurgeon at 37, Dr. Pupulampu. And over a year, I would go to him for reviews. And after a year of meeting him on a 3-monthly basis, I wanted to be a neurosurgeon. So that was it. That became my dream. That became something to talk about in between the chores, in between lessons, in the wee hours between lights out and when we finally closed our eyes. I'm sure we must have discussed our dreams. And I'm sure that by all means I said something about being a neurosurgeon. But God hears, and after all, he plants these dreams, and I think he had choreographed everything until that point. And as I continue to look forward, I know that I have the right to have a dream about healthcare in Ghana getting better, because all my dreams have come true so far. So 7 years in Achimota School was formative for me. The continuous drumming of the mantra, head, heart, hand, it makes much more of a difference than we think. The repetition of our values, what Achimota stands for, at every occasion, it just plants something into the mind. And I think the one leaves Achimota thinking, and rightly so, that we are living waters to a thirsty land, because we know it. It's been said over and over again. But I think sometimes we find out that in the thirsty land, sometimes thirst is not a need for water. It might be a need for other things, and we have to adjust and adapt. I think that all those years of scrubbing the floors, preparing for inspection, preparing for the Founders' Day, rehearsing for cadet parade and all that, it gives us the impression that when you work hard enough, you will flourish and you'll get there. And then we come into the real world and realize that maybe it's not the case, But I think our training in Achimota gets us to adapt. And I have seen many of my classmates adapt and still use those values that we have from Achimota to do great things. But I think it's still an upward struggle to do the adaptation, to do the pushing on, whilst maintaining our values. So, I kept my dream alive for medical school through all those 7 years. It did not mean that I worked hard enough. I did okay for O-levels, and then A-level was a different beast altogether, especially since I thought I was brilliant enough to do it whilst leading the choir and leading the cadet corps at the same time. I was proved wrong. When the results came, it was nothing to take home. I remember seeing my results and saying that, okay, this is a sign to go and do journalism. Because I loved English, I loved literature, I loved drama. I loved music. So I went to see Mrs. Asari in her home, because she was my literature teacher. And I thought she would welcome me with open arms. She said, "Let me see your results." I showed it to her. I said, go and do the science again. Don't come here. Until I saw her, I was like, oh, this is a sign. I'm going to sort out my journalism. I'm going to do English, French. And then Mrs. Asari sent me back home to go and look at science again. Interestingly, the next day, I met Mrs. Mate in a taxi queue from from Circle to Achimota. I got into a conversation with her, but that conversation changed my trajectory. Because after that conversation, Mrs. Mate, together with Mr. Yurinchiado, took me in, and for the next 6 months, I was in Mr. Yurinchiado's garage, working questions. And 6 months later, I qualified for medical school because of these two people. We were about 300 students who entered level 200 in University of Ghana that year. Only 75 would be chosen for medical school. First, one had to qualify for the medical school interview with a GPA, and then one had to impress at the interview. When I ended up in medical school as one of the 75, you can imagine, I just looked back to the guy who had walked to Mrs. Asari's house and just gratefully started medical school. You know, Kolebu Teaching Hospital became our home. But you know, it was not Kolebu that was supposed to be where the medical school was. Nkrumah had planned for the medical school to be built in Legon. And what was supposed to be a temporary place became permanent. So the first medical students were 41. They were supposed to be in Kolebu for a short time, and then, by the time we went to medical school, we were 75. That place has not grown in any way. But now the current class is 300. Most of that starting faculty was Ghanaian, and this continues to be the case now. It's a blessing we have created from that tradition of limited resources, a culture of world-class physicians who we have just continued to produce with those limited resources. But maybe that's why we have done nothing to expand it. Because it is those borrowed accommodations that we're still using for training students. The doctor who introduced me to the theater still teaches now. When we were in his class, when we were on his floor, we were 4. Now when the medical students come to him, they're 40. And it's still this person pushing ahead, pushing through. I meet him still. He's still very inspirational. He still works hard. And to be fair, some of the best people I know on earth are teachers from our University of Ghana Medical School. He has retired now, and I know his pension will be less than $400 because I've seen the pay slips of our surgeons when they retire. Knowing him, I know he's sorted out. He was a planner. He put everything in place. I don't have any, fear that he is going to be left desperate. But this is the reality for anybody who works in this country for 30 years and teaches students. You're going to retire, and your pension is going to be less than $400 a month. Some of the best students in this country have ended up in medical school. So it's a crucible of all the best brains that we have. Even I, with all my bombing in Kolebu, in the medical school, I was one of the top 15 students to get into Achimota school, and medical school is a difficult, grueling journey. And again, one goes through that grueling journey, thinking that you come out and you're going to be the skilled doctor reaching out into the world to heal. And sometimes you come and find a country that, has more priorities to think about than its disease. 70 of us graduated in my year. 35 of us started our house jobs in Korle Bu in the first year. The other 35 were gone. And of the 35 who stayed in Ghana, 5 of us did not have accommodation. So 5 of us purged with our colleagues. It was an orientation into a future that was to come. Because here we were, survivors of this grueling journey of medical school, thrust into an environment where basic shelter for the doctor was not taken care of. By the time I finished my internship in Korle Bu, I was confused. I had seen poverty kill. I had seen things a young doctor should not see. But I had also seen great doctors heal with whatever they had. I'd also seen patients treated with a disillusionment that only detachment can bring. And our mantra as physicians is do no harm. But it is implicit on a recognition of self, because it's only when the self is taken care of that we can actually look after another. And I think that burnout is a gradual loss of self, and it puts the physician into a sort of default mode where the physician is incapable of sticking to the mantra that we have. A car which has run out of fuel on the road stops not because it's a bad car, it stops because it's run out of fuel, period. And I think sometimes when there have been complaints about our healthcare system and the attitude of medical personnel, we should think about that sometimes people have just run out of fuel to the point where it is impossible to do no harm. When I finished my internship at Korle Bu, I started work at Bator the next month. Now it takes maybe 6 months to 7 months after finishing medical school before house job can start. And then after internship, it can take 2 to 3 years to just get a posting to a hospital. And these are 300 doctors in a class. The Bator Catholic Hospital would become the crucible of my surgical education. And it was an introduction to lifetime surgical mentors whom I would never find again. My surgical teachers in Bator were from Holland, from Germany, from Ghana. They held my hands, built me up, smiled at my mistakes, taught me again. I entered Bator as surgical novice. I left with the capacity to deal with all kinds of surgical and pediatric emergencies. And I left with a faith renewed in the fact that it was possible to do something in healthcare in this country, even with limited resources. I also left with tuberculosis. So part of my first year of residency was spent being treated for tuberculosis. I was reminded my first day in Korle Bu as a TB patient that this was not Bator. Professor Addo, he listened to my chest and he suspected it. And he sent me to the X-ray department. The radiology technician took a look at me, saw that I had lost weight. I was a doctor from Bato. I had lost weight. He took one look at me and said he wasn't going to come near me. He wasn't going to do the X-ray. Somebody told him I was a doctor. He just walked away. It took a few more minutes before somebody else decided to do the X-ray, and the diagnosis was made. My blessing was that once I took the medications, everything settled, and I was able to start my residency as a neurosurgery trainee. I still keep in touch with Bato, and I have watched it grow, actually. And it's, we talk about healthcare in Ghana, quite negatively, but there are centers where a simple model of caring works. I've seen that place grow from when I was just a fledgling doctor, and I've seen it, what it is now, and what it continues to do. The things that Bato has done for cervical cancer in this country, Kolebu cannot come close to. But it just shows what a small center can achieve with the right people, the right leadership. I think dreams are important. My life is demonstrative of this. I would push on in Kolebu, end up in Israel, then to US, and then come to Kenya, and then finally come to Liverpool for my pediatric neurosurgery. But every time I kept coming back to Ghana, because Ghana represents a lot of what is good in me. Ghana represents a lot of the blessings that I have received in this journey. And I keep coming back because I still dream, and I know that things are just going to get better. I don't know how, but they will. But I think that for a doctor to accept to stay, especially to a surgeon to stay in Ghana, we must remember, one, that surgery depends on repetition. So for me, for neurosurgery, where the patient has to pay for his surgery or her surgery, I may never get the number of repetitions that my colleagues in the US get. So I may never become as nimble as they are with their cases, just because I just don't get enough. My colleagues in the US will do 2,500 tumors in their lifetime. I might end up doing 1,000 or 500. Surgery also depends on capitalization. It costs money to buy the things that go into surgery. The training, the doing, the caring. And for a continent that has 1% of the world's surgeons, we must guard our expectations of the kind of impact that we see. The last thing I must know as a surgeon in this country is the fact that if I get a stroke or a cardiac event, my likelihood of surviving it is zero or almost zero, even if I get it whilst I'm working in a hospital. Now, that is the ecosystem that we work in, and that is what we must do, whatever we can, to work with. Ghana has one of the highest road traffic accident mortalities in the world. But Ghana has neither helmet enforcement, road building policies or guidelines, or even an organ transplant policy. Because we're a young country. Half of us are under 19. So the people who die are the economically active people in in our society. We lose young people, healthy people, because we have ensured that our roads are basically a factory for road traffic accidents. We make sure we do not have dual carriage roads. We make sure we do not have pavements. We have all these people riding motorbikes and without helmets. And we have the policies for each one of these. But there's the enforcement that we need to do. This year, stroke became the top killer in Ghana. Now, the kind of stroke that kills in Ghana is the one which is from bleeding in the head. Under normal circumstances, stroke has two types. Either the blood vessel gets blocked or the blood vessel bursts, right? Now, in the US, 80% of stroke would be blood vessel blocking, and then 20% will be blood vessel bursting. In Ghana, it's the reverse. So it's 80% of young people with blood vessels rupturing. And that is where you need neurosurgeons. And that's where you need intensive care folks. But this is where we have 29 neurosurgeons for 35 million Ghanaians. And ICU beds have not increased in number since COVID. If anything at all, the people who man or woman ICU beds are skilled nurses. They're leaving for greener pastures. And incidentally, now they're even being signed onto programs which take them to countries which seem to need skilled nurses much more than Ghana does. You know, losing young people to road traffic accidents and stroke is tragic. But it's not as wholly destructive to our country as losing experienced medical staff. These are people who have resolutely endured the path that I have described. Because for my story, there are hundreds, thousands of young Ghanaians who have gone through this and who have come out as medical doctors, pharmacists, right? And now, if it takes 2 years to post somebody who has finished his internship, who has finished his house job, they go. They just leave. They will not sit at home and wait for government placing. When, post-COVID, the UK, the US, they have places that need a lot of doctors, so take them. Our capacity to diagnose disease has improved because the private sector has interest in imaging and laboratory technology, but the capacity to deal with surgical challenges has not changed. People who have resolutely finished medical school are sitting and waiting. So, we're a young country, like I said, and I think when you're young, sometimes healthcare is not exactly important, There are not too many 20-year-olds, 30 years who go to their hospital and do screening every year. No. So I guess sometimes it sort of shows why, as a country, we think about healthcare like that. It's not our priority. And actually, Ghana signed the Abuja Accord to ensure that we would spend 15% of our GDP on healthcare every year. In 23, we spent 7%. And we haven't changed much. We're still there. The other thing is that we have not increased our knowledge of the problem. You know, take the typical healthcare issue on radio, and it's usually not being talked about by a healthcare expert. You know, we have a lot of signboards of people, you know, broadcasting the news of healing hypertension, healing stroke, healing cancer, right? And when we're not creating the information that is important for all of us to make decisions, we're also not diffusing the wrong information. And so we are not really improving our knowledge of the healthcare challenge that we have. At the moment, I work in a private hospital which was started by a couple in Osu. And sometimes I can only do some procedures in neurosurgery because I work at that hospital. We've done procedures there that cannot be done in Korle Bu because there's no capacity for it. I thought I could combine private and public, you know, like it's done in other countries, but we haven't gotten our ecosystem developed enough to leverage that. It's still possible, but we have to get to the point where the few neurosurgeons that we have can cover multiple hospitals, and it is just straightforward. When I was in Alderhay, we were covering hospitals in Wales from Liverpool. They would call, they would bring patients, and they have multiple times more neurosurgeons than Ghana has. But the neurosurgeon in Tema cannot move to Korle Bu to do a case because we haven't ironed out our procedures so that we can really optimize on the expertise that we have. The Accra Medical Center is one of the few places in the private sector where complex neurosurgery can be done, right? And it's also the only building in Accra where you have on the same footprint theaters, CT scan, and imaging. I mean, theater, CT scan, and ICU. It's the only building in Accra where I can do a brain surgery and the person doesn't need to be taken out of the building to do a CT scan. All I need is a lift, do a CT scan, and go to the ICU. Why is it the only building in the private sector? Is anybody holding anybody's hand from spending money to do this? You know, this small private hospital is surrounded by public hospitals. And recently, you know, every now and then there's an ambulance wailing to the hospital, coming to do CT scans and go away, because around us, all the public hospitals' CT scans have broken down. So, why can't these arrangements be formalized so that, well, okay, it's not happening, so let's get our NHIS to cover these things that are done outside the hospital. But this is where we need a back office to write down and to strategize and to think about these things so that we can, you know, go over the challenges that we have and use them to do great things. You know, the expenditure of our government on healthcare, it just mirrors the expenditure of our own selves. Korle Bu is the largest hospital in Ghana and the second largest in Africa. It has 2,500 beds. It is possible to walk through the whole of Kolebu and not see one building more than 3 stories which has a Ghanaian's name on it. It's not possible to walk through Johns Hopkins for 5 minutes and not see a building that has somebody's name on it. How come Kolebu is going to be 100 years? It's 100. And we don't have a single building more than 2 floors which has somebody's name. We don't have a single endowed professorship. We don't have a single laboratory that is funded by a private individual. The top killers of Ghanaian youth: hemorrhagic stroke, traumatic brain injury. Unfortunately, they all need specialists. They need specialized ecosystems to take care of these people, right? We need to do research, we need to do training, we need to do development of capacity so that we can make sure that these people who are involved in so many road traffic accidents can survive. In 2023, the US spent $4.9 trillion on healthcare. Norway has 5 million people. They spend $49 billion on healthcare, right? Ghana has 37 million people. We spent $14 billion on healthcare. The top 5 companies in the US have 2 healthcare companies amongst them. I was looking at the top 50 companies in Ghana. It's number 50 is a healthcare company, right? You know, in the US, the only industry that is richer than healthcare is weapons industry, right? So, I am not a money person, but if I had billions of dollars, I would invest into specialized healthcare for Ghana, because I have seen the whole of West Africa comes to Ghana. Usually they come for holidays. But the truth is, we have traffic, right? And in Sierra Leone, there's 1 neurosurgeon. In Gambia, there's 1 neurosurgeon. In Liberia, there are 2 neurosurgeons. In Ghana, there are 27. So if they wanted somewhere to come for specialized healthcare, they would come. And if we built around this, I think we would make much more money than some. So I'd just like to conclude with these thoughts. I like the fact that Mahama Care has placed non-communicable disease on the table of decision making for this country. I also like the fact that the National Health Insurance is increasing its coverage of disease, and that maybe neurosurgery may finally be covered on the National Health Insurance, considering the fact that neurosurgery is needed for the top 2 killers of young people in this country. I love the fact that the Ghana College of Physicians and Surgeons is taking the lead to train more specialists and more young doctors to meet the need for specialized care. And I'm also grateful that increasingly private hospitals are taking up the mantle of specialized care and even going into global medicine and leading surgical missions that bring procedures that would otherwise have been unavailable to Ghanaian doctors. I think I've shown by what I've said that I have always been a dreamer, and I'm convinced that things will get only better. Recently, as I have labored to acquire management skills in the private sector, I have learned to appreciate the meat pie seller that I meet on the N1 every morning. She has her company on her head. She has a board of directors at home. She's doing her customer surveys on a daily basis. She's sorting out quality control, bookkeeping, all by herself, and she turns up every day. And I see so many people like her on my road to work, so many people. And I have also seen people like this in healthcare. They turn up, they push forward, they do the best they can. They get broken, but they get up and keep going. And so I do not give up hope. I think the best is yet to come for specialized healthcare in Ghana. Thank you.
Wow. Oh, Accra, sit here. This is your seat. I don't know about you, but I was transfixed by what he was saying. I think we need to appreciate him again. May your dream come true, because all the other ones have come true. So this one there, it has to come true. Makes you afraid to fall sick in Ghana, doesn't it? The young people are worried. His dream will come true, don't worry. Okay, so we're going to have a panel discussion right now, and I have two brilliant panelists who I want to bring onto the stage. First to join Teddy up on the stage is a product of Fernhill Manor School in the UK, Achimota School, and the University of Ghana Medical School. Our distinguished panelists practiced in Ghana and the UK, and on returning to Ghana, joined the National Health Insurance Authority, working there for 15 years and becoming the chief executive before retiring in 2022. Our panelist since then has been involved in consultancy roles in the health financing space with a focus on efficiency of expenditures linked to improved outcomes. An active member of Zonta International, an international NGO dedicated to building a better world for women and girls through service and advocacy. Let's welcome onto the stage Accra Dr. Lydia Jani Selby. The last seat belongs to a seasoned consultant with a reputation for transforming healthcare systems across sub-Saharan Africa, having led initiatives that bridge the gaps between innovation, efficiency, and quality in medical delivery. As principal advisor to governments, private institutions, and development partners, our panelist has a mission that has always been clear: to elevate healthcare outcomes through strategy, safety, and excellence. Our distinguished panelist plays a pivotal role as senior consultant and partner with a global healthcare advisory firm that is dedicated to improving access to quality care in emerging economies. Early in their career, they steered one of the world's top pharmaceutical companies as regional director for West Africa, overseeing operations in more than 30 countries and shaping policy, growth, and governance across the region. Beyond the boardroom, our panelist shares something with our keynote speaker: music, art, and golf. Don't know whether Teddy plays golf. A fitting balance for a man whose precision defines both his game and his work. Let's welcome William Delali Ofori. Okay. So we will jump into the conversations. First of all, with thoughts from the panelists. So Dr. Johnny Selby, our theme is healthcare or death care, and you heard from Dr. Totime. What are some of the initial reactions to what you heard and our theme as well? Feel free to riff from both of them. Let me put it on for you. Let's see.
Thank you very much. First of all, when I first heard the topic, I must say my heart missed a beat, because I'm usually, or in the past, I was usually the villain of the piece, being the CEO of NHIA. But I think today, listening to Dr. Totime, it's taken a slightly different turn. I'm not quite the villain, and so I can share some of my thoughts. While you were at Achimota, I was the Achimota hospital doctor.
I see.
Did you take care of him? Possibly.
I don't remember him coming to the hospital, but yeah, so I think for all of us, we're concerned about the kind of backward steps we've taken. I was in Kolibu Medical School as well, and I remember the fevers unit. I don't know how many doctors are here. We had a fevers unit in my time, and during a certain time of the year, it was filled with children with measles. And I had this conversation with Professor Irene Japan, who is not here today. And I remember us both saying one of the reasons we wanted to get out of clinical care was the sheer number of children who died every day in the fevers unit from just measles. But today, we've taken some steps forward. Ghana, I think, hasn't had a measles case for a very long time. And when one turned up in Tamale, they had to bus in student nurses and medical doctors to see the child.
This is what measles look like.
Yeah, because we hadn't seen it for so long.
Wow.
So we have made strides in sort of the routine care type things, infectious diseases, malaria, diarrhea, and all that. And now we're left with the non-communicable diseases and how we need to tackle them. And I think for some of those, it has to be a quid pro quo between the medical personnel and the public. At NHIA, we did a survey on people who don't come for follow-up when they're diagnosed with hypertension. Men between 40 and 60. Even when they are told they have hypertension, they are shown the numbers, they get angry because they have no symptoms. They don't want to come back until they are lying on a table and they are calling for Dr. Totime to come and do surgery. I mean, it is, how many men in this room have had a BP check within the last 2 months? Those who have their hands up, I'm sure they are lying.
Oh, we can't win, we can't win.
No, it's a fact. But the women are more circumspect about these things. There are no symptoms for diabetes and hypertension. So you want to wait until you're lying on the table and somebody is screaming for Dr. Totime before you come. So there is an issue about balance. But I also think, having come from the finance side, we need to look at efficiency within our health services. The doctors are at the top of the tree, but below them, there's a lot of inefficiency. We're not getting the biggest bang for our buck, and that is a fact. And we need to sort that out if we want more money. Then equity. I was invited somewhere about pediatric stents for pediatric cardiac cases. Each stent is $20,000. And I was...
What's a stent for us non-medical people?
It's for, to open up blood vessels, right, in the heart.
Okay.
Yeah. So for children, it gets very traumatic if they have heart problems. But the stent costs $20,000. How much how far can that $20,000 go in rural Ghana?
One stent?
Yes. Compared to one stent for a child in Accra who's likely to come from an elite family. And I was highly embarrassed and had to walk out of the program. So it's about equity. You know, we cannot have policies that are only for the elite. We have to think about the rural areas and fair practice. There are counties in the US with all their spend Their maternal mortality rates are worse than Choco. So sometimes following America is not always the way to go. So we need to look at things that benefit all of us for the money we have. Regulations and policies. You were talking about it. Ghana has some of the best healthcare policies and regulations in the world. When I was at NHIE, all the African countries came for some of these things. But we don't follow our own policies. I went to Rwanda to talk to them about our health insurance. Within 2 years, they changed their program to be more like ours, but then they implemented it better. So they are getting better outcomes. Our institutions are being broken down, mainly, I'm going to say it, due to politicization. You know,
please say it. It's called Achimota Speaks, so please say it.
We're not following meritocracy. You know, you have to know somebody to be the head of the institution. When sometimes there's a better person who is apolitical who could actually run the institution well. And we need to say it. Privacy. I had surgery in a hospital here about 4 years ago. And within 24 hours of my being there, virtually every head of department came to greet me because they had heard the CEO of NHIE was there. Will I go back again? No. I'll go somewhere else where nobody knows me, so I can have my privacy. And I bet you that happens to a lot of people. So people are not running away because they don't trust the doctors. Because I know I'll get VIP treatment in Ghana because my mates are all there. But you also don't want the whole hospital to know why you are there. Yeah. So that is something we need to address. But my biggest gripe is political interference, sacrificing good policies on the altar of political expediency. When money comes, we're going to buy 20 Land Cruisers instead of 100 incubators. That is a fact, because the Land Cruisers are showy. We're going to build a nice, new, shiny, big building with nothing in it, because you can take good pictures and be all over social media, instead of doing what is right for the people of Ghana. Now, Teddy, you talked about the Abuja Declaration. When health insurance came, the point was the Ministry of Health budget is there, health insurance will be there. The two of them would get us to the Abuja Declaration. After a few years, whatever health insurance brought, the Ministry of Finance cut that amount from the health insurance budget. And we stuck at the 6-7% for about 15 years. That is why we're not going forward. So these are some of the things nobody talks about. I'm retired, I can say whatever I like.
We thank you for that. Achimota Speaks indeed. I love it.
So I think all in all, money is important, but I think America has shown us that money isn't everything. No. The elite get taken care of. Those at the bottom are suffering. They're as bad as we are in Ghana. So there has to be a balance. But I think the biggest issue is priorities, letting the technocrats
do their work,
run the system, right, and not the politicians.
Okay, let's give a big hand. Very well articulated. Mr. William Delali Ofori, it's your turn to riff off the theme and then what Dr. Totime spoke about.
Okay, so I'll start with my introduction. And, you know, I always find it very interesting when people use America as a yardstick. Because in the top 15 countries in healthcare, America doesn't even feature. It's not the yardstick for quality in healthcare. Now, I'm going to attempt to talk about the good, the bad, and the ugly. And say it as it is, because it's Achimota Speaks.
Right behind you.
Dr. Totime gave me one flashback when he talked about if he had a stroke. A few years ago, a very good friend of mine, arguably one of the best vascular surgeons in this country, was on his feet operating for 12 hours. He went home, he collapsed. He was brought into the emergency of the same hospital he worked, saving people for 12 hours. He lay at the emergency for a while, unattended to, until somebody recognized him and they took action. It was a little too late. He died. Now, to give you a scope, there may be 2 or 3 vascular surgeons in the whole country of 35 million or 33 million. But I think today, if we wanted to do justice, we'll have to cut across the whole healthcare spectrum, from pharmaceutical care, nursing, laboratory, etc. We may not have the time. But I think it is possible to make a difference. I remember a friend of mine, Mrs. Darko, who sat in class with me, started her post-national service job at Pharmacy Board, ended up at Food and Drugs Authority, and transformed that entity into one of the best pharmaceutical regulators in the entire Africa. Today, she's the first Director General of the Africa Medicines Agency. So it is possible. October, what was everybody talking about?
Breast cancer.
Thank you. Do you know how the October breast cancer campaign started? I was one of those who started it. I had a cousin who had breast cancer, but detected early and lived for a very long time. I had an aunt who had breast cancer, was detected late, and died soon after. I sat with some groups of doctors in Kolebu in the early 2000s and decided, why don't we start this awareness campaign? Because we do it internationally, so why don't we do it in Ghana? We brought a container load of posters, leaflets, and silicone breasts for teaching. Fast forward, other entities like Breast Care International and all that came in. And in the last few years, it became a nationwide campaign. Nobody remembers the individuals who started it. I have their names. Half of them are in Kolebu. In fact, most of them are in Kolebu or were in Kolebu, starting with the late Prof. Bedu. And a couple of them were in Konfanochi. But is it healthcare? I think it's attempted healthcare. Because as a nation, I don't think we are intentional about improving healthcare delivery. And I'm not talking about edifices or procurement deals or fancy policy documents. Albeit we have some great policies and frameworks on paper, execution is the problem. We don't know how to execute. So healthcare in Ghana, to summarize, is delivered suboptimally due to either non-motivated personnel who think they deserve more before they work, or self-motivated individuals like Dr. Totimi, trying to put in their best, but many of them frustrated because they are either unappreciated, under-resourced, work in poorly equipped conditions, poorly maintained facilities, and all these have an overarching issue of suboptimal processes, systems, and controls. They're almost non-existent. And I've traveled across the length of breadth of this country. I have interacted with a lot of healthcare personnel in different institutions. The functionality of many health facilities, both private, and I mean both private and public, are driven positively or negatively dependent on individuals. There are no or minimal standard operating procedures, processes, and controls. And I can give you a few figures and you understand that. And that impacts everything from your CHIPS compound to your tertiary and quaternary hospitals. It's the same story. The story is no different. So we may have a semblance of death care, mainly due to a myriad of dysfunctional parts, lack of accountability, inadequate collaboration. Dr. Totime mentioned that. And controls. And there's no timely action. So I'll pose this question back to us. On a typical night, 9:30 p.m., if you suffered heart attack, massive stroke, road traffic accident, got burned, poisoned, choked by some sharp object, which I encountered myself recently, have a bad asthma attack, life-threatening allergy, snake bite, where would you go? Where would you go? Name the hospital and I'll tell you the pros and cons of every hospital you will name. And everyone will be dependent on what particular issue you're dealing with. And I get calls and they're like, William, I'm rushing my dad to this place. And I say, no, don't go there. If you go there, unfortunately, he'll die by tomorrow morning. So make a U-turn and go to this place because this is what the problem is. Maybe for another issue, it'll be okay for him to go there. Okay? But at the end of the day, I think that to get into the discussion, we realize that for a nation to be healthy, you need health, economy, education, infrastructure, food security, and housing. And for a good healthcare system, health service delivery, health service financing, healthcare infrastructure equipping, healthy workforce, access to medicines, diagnostics, and technology. And then underpinning all this, leadership, governance, and accountability. As for the reports, we have many. In the last 2 years, we've had report on harmonized health facility assessment, health sector minimum term development plan 2024-2023 steps, report on non-communicable disease risks factor assessment, Ghana health data, including mortality data, holistic assessment of health sector. We have plenty, and we have the regulators. Did you hear in October, HEFRA was going to close down about 200 health facilities, from midwifery facilities to big hospitals, in Ashanti region alone. Today, HEFRA closed Tamale University Hospital, Technical Hospital, due to poor conditions. Poor conditions. This is Tamale University Technical Hospital. A few weeks ago, they closed one private health facility, which most people think is a top facility. They have 3 outlets in Accra. They have been operating without license for 10 years. But we all go there. When you check the data and the statistics, I don't think we are doing well. Preventative health and curative for children, yes, 93% of facilities, access to newborn services, 81%. However, care for newborn, small and sick newborn, 15%. So yes, you have 80% delivering the babies, but only 15% can look after them when they are sick. Ultrasound, you can find in 27% of the 1,400 plus facilities surveyed. X-ray, 6%. This is the public sector. And that's why Dr. Totime talked about the complement of the private sector. When you talk about other imaging, CT scan, etc., 1% or less. So should you find yourself in trouble anywhere, you are in real trouble. 88% of all our doctors and I haven't even counted nurses and pharmacists, are in Greater Accra and Ashanti. We have some great institutions, National Health Insurance, and I'll tell you something, one of the best things is Muhammad Cares and the uncapping of the health insurance. But it all depends on how we will execute it now. Because prior to now, if you had 10 requests, 5 medical requests, and 5 medications, so 5 procedures, 5 medications, the average facility that takes National Health Insurance can cover not more than 40% of either your medication or your services. There are over 5,000 pharmacies in Ghana. Over 5,000. Less than 150 serve on National Health Insurance. So you say, what about private insurance? Okay, let's look at the numbers. National Health Insurance has enrolled now, the latest figure I had was 18 million. That's about half the population. Private health insurance covers less than 2% of the population, 1.5 to be precise. So if National Health Insurance is not optimized, where do we stand with private health insurance? When you hear an ambulance going anywhere, it doesn't mean that the person has been rescued. Because I have seen ambulance go through traffic, 20 minutes to the health facility, 40 minutes the patient is still in the ambulance at the health facility. People come out of the ambulance and in 2 hours they haven't been attended to. There are global standards for what emergency room process should be like. And it really is a matter of hours. But our design is flawed in our hospitals because people stay in the emergency room for 1 week. And so half the time when you hear of no bed syndrome, it's just there is nowhere for triage. There's nowhere to accept the patient. So there might be beds on the ward, but they can't accept the patient in the hospital. There's almost no communication between an ambulance and the receiving center. So we have all these. And then we know that he talked about non-communicable diseases. So the top 10 killers, stroke is the leading. But among the top 10, ischemic heart disease, diabetes, kidney disease, and cancers. Do you know that as of 2014, the whole Ministry of Health Non-Communicable Disease Department had 2 doctors, a total of 7 staff for the whole country. And they were doubling for non-communicable diseases for Ministry of Health and Ghana Health Service. Today, there are a few more, and they have 1 regional coordinator per every region. For what accounts for almost 49% of all deaths. Are we a serious nation? No, I don't think we are. I don't think we're a serious nation. We have not yet identified how we're going to deal with healthcare in this country. Finally, before we throw it out to the rest of the discussion, Dr. Totime said there are 27 neurosurgeons. Okay, let me give you some statistics. Interventional radiologists, there are either 3 or 4 in the whole country.
What do they do?
Dr. Totime is better to tell you that.
What does an interventional radiologist do, man?
So interventional radiology is a branch of treatment where you use X-ray as your visualizing tool. So the X-ray sees through the body, and then you can use a wire to, instead of making a cut, you introduce the wire into the body. You use the X-ray to follow the wire. The thing is that then the wire can do things to your heart, to your brain, and so they can, close off an opening in a blood vessel, for example, without cutting anything, right? So what would usually have been done with a huge cut from here to get a blood vessel and deal with it, you can use the X-ray to look at the wire and go through it and do it.
Sounds like a video game, man.
It is.
Mr.
So
Fori,
now I know that made you sad, but let me go through a few more. Interventional cardiologists. We said non-communicable diseases are the big killers, including ischemic heart disease. There are, I think, 4 Ghanaian interventional cardiologists in this country, and a couple who come in and out. And then there are 2 experts, I believe, consultant rheumatologists for all your autoimmune diseases. They are 1, 2, 3. Endocrinologists, 12 or 16 maximum, with other diabetic specialists, not more than 30. Vascular surgeons, I think there are 2 or 3. So I know there was all this hullabaloo about a cath lab in Konfanochi. Who's going to man it? We have 4 interventional cardiologists here. So we need to build capacity. You know, emergency medicine specialists. You know, it's a big problem. We haven't even hit the tip of the iceberg. Now, when you look at the health assessment reports that I talked about, nobody met in all the reports 2023, 2024. Public health facilities, none met 30% of any target. But it's very interesting. Vehicle maintenance, 55% of them had vehicle maintenance up to scratch. Hospital equipment maintenance, maximum was 11%. Now we're talking health, but vehicle maintenance is priority over equipment and facility maintenance. Doesn't make sense. But this is the reality, and this is not me saying. Right. These are reports of surveys done with Ghana Health Service, Ministry of Health, WHO, development partners in collaboration. That is the state of our healthcare. Okay. So the average CHIPS compound, if you take, and there are over 7,000 of them, basic equipment, what is it? SFIC, weighing scale, thermometer, examination bed, medicine kit. Of the 6, not 20% have more than 3. It's scary. And I can go on and on. It will take us 3 days. Then we'll go to nursing care, and I'll go to laboratories where you won't trust the results, or pharmacies where I wouldn't buy my insulin from. Yes, because if you look at the data, whether hospitals or private pharmacies, where temperature regulation for these things should be kept optimal, a number of them fail. Right. And that is why you would go to specific places. Mm-hmm. So we do have a big problem. Like I'm saying, that's why we are happy that there's a concept like Mahama Cares and uncapping the national health insurance. But the big issue is, like many of our good policies, how do we actualize this to transform outcomes? Because very often we talk about the nice policies. We don't measure outcomes. Now, I'll give you a shocking revelation. You know, if anything was to happen to me, Kolebu is still one of the best places to be. But can you imagine that at a point in time, Kolebu lab was running at a loss? If you shut all functions down and you just pay salaries, because you've made provision for salaries, you just break even. But when you outsource, they make profit. This only makes sense in healthcare in Ghana. Thank you.
Thank you very much, Mr. Fori. Wow. It looks like a doom and gloom story, but we're going to lighten the mood now because we need some solutions, things that will make us smile. We need Dr. Techime's dream come true. So I'm going to start with you first, Dr. Techime. I mean, you've heard from Dr. Jenny Selby, Mr. Fori, riffing off the theme, what you spoke about. What are some solutions? Apart from dreaming. No, we're not praying. We're not praying. We prayed when we woke up this morning. We want solutions.
We recently did a mission, a neurosurgery mission. And for the first time, 3 surgeries were funded by clients who had been to the hospital and had surgery. And they just said, we want to fund these surgeries. And they
out
did.
Of gratitude?
Out of just philanthropy.
Yeah.
And this was the first time I was seeing it, right? Like I was saying, in the long run, it's all about money. It's all about advocacy. It's all about us bringing the problem to the public and saying, this is what it is, and encouraging giving towards the problem.
How do we retain the nurses? How do we keep the nurses here? How do we grow more specialties? I mean, the numbers are frightening. I mean, 27 of you, 3 of rheumatologists. What's the way out, man? How are other people doing it?
Just put a building with somebody's name in Kolebu and dedicate it to cancer. And you will get people to come in and do it. The thing is, if we do not have money going into healthcare, we cannot retain these people. I know money is not everything. However, I think that we haven't spent enough, and we won't get back what we. I've always advocated for the fact that when you could talk about solutions, this is a bit sacrilegious, but I think that we should have a funeral tax, for example.
Funeral tax?
A funeral tax.
A year tax?
Okay. Because...
How would it work?
Because the thing is, you see, the typical funeral in Ghana, right, would require that first kept in the fridge for a certain period of time, right? Now, if we decided to cut down that period and put that money into healthcare, it would make sense, right? But I'm just saying that if we looked for ways to put money into healthcare, we would find ways.
So it's a money matter?
It's a money matter for me.
Dr. Johnny Selby, so financing of our health system, I mean, you're on retirement now, so please feel free to speak.
Yeah, I will. For me, the issue about taxes is nobody likes to pay tax. You only pay tax if you think there's something at the end of it. When the health insurance tax was passed, the fact that it was going to stop cash and carry, nobody complained in Ghana because they felt they were getting something out of it. I worked in Kolebu during the cash and carry era. It was awful. Sometimes we'd use our own money to buy notebooks and tear pages out to write the patient's notes. Somebody lost their life delivering a woman with hepatitis, and the doctor ended up dying. There were no gloves. So I lived in the cash and carry era. We didn't go to the UK because we wanted a bigger salary. We went to the UK because we're tired of patients dying in our hands.
For our Gen Z people, what is cash
it.
and carry for the Achimota students who don't know?
Okay, cash and carry in those days was when you get to the hospital, you put money down before they'll even take your temperature. So you could be there looking for money and die. It was as simple as that. There was just no other way around it. And for those of us who were working there, it was very traumatic. Very, very traumatic. And, when I went to Achimota Hospital, it was a bit of a blessing because the doctor, there was only one doctor's house or whatever, accommodation. So I went to the headmistress and said, I'm an Akora. I can be posted here. Give me a bungalow and all the students will be my priority. And they gave me a bungalow. And my bungalow is now what is the Achimota School Clinic. You know, when Ghana Health Service took over the hospital, my bungalow became, the current clinic is where I used to stay. So I was right next to the hospital, always at the beck and call of the students. But if people can see benefit, they can pay tax. If you try to increase the tax and they can't see extra benefit. My job at NHIA at first was clinical audit. I went around every facility and to see the standard of care, but also to see how they were spending when they were paid. The first thing they did when the big chunks of money, the medical soup got an upgrade to his office, new carpets, new curtains, new air condition, and everybody bought an SUV. So that the medical soup would be sitting in a Prado or something before they paid the pharmacist.
Who's medical soup?
The medical superintendent of the government.
I thought it was a dish, right? That was one of those
No,
kinds of-
sorry.
Okay, all right.
So it was only when the pharmacy company started complaining that we went into the books. And yeah, new air conditioning, new curtains, new carpets, new SUV, before they paid for the drugs and gloves and stuff they had used. So when things like that happen, who wants to pay more taxes? Yeah, I'll pay what I have to pay. I want to use the rest for my holidays abroad and stuff. Why should I pay tax?
So clean out the system, let people see what they're going to get.
So we need to clean the system. If Ghanaians feel everybody's health will be taken care of, I'm sure they won't mind a funeral tax or communication tax or something. But there's got to be accountability. Public Accounts Committee, when the health sector is called, do you see some of the things that happen? We paid health insurance money. The accountant built a house. When confronted, he said he hadn't stolen the money. He had borrowed it.
From which bank? Bank of...
The bank of the hospital's
NHIA.
accounts.
Wow.
So these are the little things that are not helping us. And as you said, it's about accountability. Nobody gets punished. He'll be given time to pay you back interest free, but he's living in his nice 4-bedroom house somewhere. So the money, I don't have the answer. It's good that the health insurance has been uncapped because it is a lot of money.
What is the significance of this uncapping for those who don't know?
Okay, so 2.5% of everything spent in this country is taxed and put in the Ministry of Finance's account, and is supposed to be released to health insurance every month actually, by law. But it doesn't, it just gets mixed up in the whole consolidated fund, and we have to beg and beg and beg before it comes back to us. And you have sympathy with the Minister of Finance. This is a huge pot of money. He doesn't want it to be spent on operations when he can use it to pay salaries of the ministry staff or whatever. So every time it's a big fight to get the money released. Then they decided, okay, the money is too much anyway. They're going to keep 15% forever. And that was the capping. Well, we know people. So we kept strong records. And Parliament told them to give us the money back. But, you're giving it to us 3-4 years down the line. The money has lost its value. I even had a dashboard from GRA, so I could see exactly how much had been collected.
Did he make you smile?
Live dashboard.
Live, wow, see. Like the elections.
So when you owe 1.1 billion cedis,
you can see,
and you are not giving any of it, yeah, the pharmacies are annoyed. The hospitals are annoyed. They can't buy drugs. They can't pay salaries. But Ghana is also having problems. So that 1.1 billion is not sitting there idle. It's being used for something. So this is where the finance situation comes in.
Okay.
Yeah, so I still don't think money is the total answer.
All right.
But yes, some money will go a long way to helping. But Teddy, I blame you. Neurosurgery never lobbied for some parts to be added to the health insurance. It's not too late. That's what the childhood cancer people did. They lobbied, they cried, they tugged at my heartstrings. I went to Parliament. They are in there.
Teddy is preparing his
You
response.
need to lobby.
He's preparing his response. He's preparing his response, but and Delali wants to come through. But I want to go to the audience. Remember your response, and I'll come back to you too. This Achimota speaks. The microphone is for you now. Healthcare or death care? Where are we going? Yes. First question. Name, brief.
No, okay, so I'm Harold Eseku. Not really a question. I did some work on water sanitation and hygiene in healthcare facilities in Ghana, and I was traumatized. You go to hospitals, and to deliver, you have to bring 6 jerry cans of water. You, as part of the equipment that you're supposed to bring as when you're going to deliver, as a pregnant woman, there's no water in the hospital. So you bring 6 to 8 jerry cans, 4 gallons of water to the healthcare facility so that the woman can deliver. And there's no toilets. So when you deliver and you need to go, you may have to go to the bush. So it is better to go back home immediately rather than stay there and have to poo. So that was the kind of, and I was just telling him, you have when a project sends the bins which you can poo, it became good for storing water.
The Bola bin.
Yeah, if it's new,
Yes.
it makes more sense.
It's a container.
Yes, it makes more sense to put water in it. It's a very durable container which lasts for a very long time.
But where did the Bola go?
Oh, it can go anywhere. That is a secondary issue. Water and Bola, which one would you? So for me, coming from outside and going into the hinterland and seeing the kind of stress that people had to go, pregnant women had to go through. I was traumatized. I took pictures. I still have pictures on my phone from about 10 years ago of that experience I had of water sanitation facilities in healthcare facilities in Ghana.
Wow, what an experience. Microphone is available. Yes, quite a few people. Okay, good. Yeah. It's on.
Just out of curiosity, what did you do with your findings or the report? What was it used for?
We have the national policy on water sanitation and hygiene and infection control in healthcare facilities in Ghana. The policy has been developed, and I'm not a health professional, so I handed it over to them.
Please be taking note of the contributions.
The policy was developed, so with hand washing facilities and all that. So when COVID came, one of the advantages we had in Ghana is that we already had a policy on hand washing in Ghana, which could be implemented immediately. Yeah. So
information like this can be passed on to the media or to civil society organizations because it definitely requires advocacy. Imagine putting this experience you had out there. It will be picked, it will be carried by a lot of newspapers, radio stations, and whatnot. And, in the process, I think somebody somewhere will listen, pay attention, and respond. How can women who've just delivered use, free range? It's unheard of. Anyway.
Thank you very much for your contribution. There's a question. Yes, sir. Your name and your contribution.
Ibrahim, if we are trying to think about solutions, right, let's take a simple, specific example. Last I talked about a physician who was one of 2 in Ghana. He worked for 12 hours, went home, came back to the facility, and died. So let's look at his example. Let's take it that he's a very good physician, a very dedicated physician. So he was doing his part. but the entire medical experience in his hospital failed him. So even though he's a good doctor, being a good doctor was not enough to let the procedures of the hospital be good enough to save him. He came to emergency. No one looked at him until someone found out that he was a physician over there. That is the root of the problem. That is one of the roots of the problems. So this is just a very simple example. You being a good doctor in a facility is not enough to make the facility fit for purpose. Once someone gets to you, you can do your job. But what about all the things that need to happen before the person gets to you? And what about all the things that need to happen after the person leaves your care? If we cannot answer what could have been done in this specific case, then we can't solve the problem. Money will not help. If you look carefully, all of these problems we are talking about, the roots are the same and they are one. But let's not make it abstract. Let's just take a look at just a doctor. Dedicated doctor. You worked for 12 hours, went home, came back to your facility and died. You died simply because your facility was not set up to give anybody good care. Whether it's how they do triage or anything of that, your facility let you down. And if you, a good doctor, don't have enough pull or understanding or whatever it takes to make your facility good, then we have no hope. So let's just look at that small example, till we can figure out what can be done or what the lever points are to make that difference, then it doesn't matter any of the other problems. Because we can't do it. We just are incapable.
Thank you very much. We have a student who wants to, yes, from now on we'll all stand so that the camera can catch us.
Good evening.
Yes. Good evening. Your name?
Mine is more of a suggestion.
Yes.
So during the discussion...
Give us your name first.
Munko Kwanzi. During the discussion, it was spoken of the majority of the more experienced doctors being stationed in Greater Accra. So my suggestion is, rather than keeping all the experienced old doctors in one place, why not dispatch them to deprived areas with accommodation, with those currently entering the healthcare delivery field, so that the newer generation can learn from the old. And not only will this go a long way to solve the problem of high mortality rates in these areas without medical personnel, but also ease the problem of unemployed doctors. Thank you.
Thank you very much. Please be taking note of all these so you fuse them into your closing remarks. Okay, there's a hand here.
Good evening. I'm not sure whether what I'm saying is relevant, but I'm alive. I'm actually alive because of Dr. Totime. He probably doesn't even recognize me. But, oh yes, I was bleeding, and you see, my situation was about healthcare and death care. I was in one of these very top-notch hospitals, and due to the how the attitude of the nurses, something happened. I fell there and hit my head. I was unconscious for a short while, so I didn't know that I didn't realize anything. Anyway, whatever happened, son, I was bleeding in my ring. So, and maybe it wasn't my time to go. 8 months after, I was just getting headaches. I don't get headaches. So I was just getting headaches. And so I reported to my doctor. And she asked me to do an MRI. Anyway, long story short, I was referred to Dr. Totimo. He was then at UGMC. Very, very unassuming, humble guy. When he was ready, he had to operate immediately, do the brain surgery. I was like, yeah. Anyway, he was ready to do it, say, on a Friday. He couldn't get the full compliments of the people. He spent the whole day by me, checking on me every 30 minutes. I had been wheeled to the pre-op place, wherever. But I think somebody didn't, the anesthetist or whoever didn't show up. So I had to be wheeled back into the ward. And then he promised me that will you the next morning. And then he operated. 2 days I was out of the hospital. So you see, it's healthcare and death care. I'm not a very good orator, but bottom line, it's a long story. But Dr. Totime, I came because of you. Thank you.
Thank you. You said it quite well. You're a good speaker. You said it well. Yes, sir.
I also want to take this opportunity to thank Dr. Totime. He doesn't know me, but I know him. Today happens to be the second time I am meeting him. As I sat here, I was just discussing with Beza that you saved my ankle. Now, we're talking about solutions. Human relation is key. And when somebody visits your hospital, even when you don't have what it takes to solve the problem, the father will just walk to the person, try to find out what is happening, and they give that person hope and comfort. You are on the verge of saving that person. And the typical case is my uncle, Mr. Opon. He was having severe headache. And then somebody recommended you. My uncle, Thomas Boensi, got in touch. We placed a call to my uncle in Kumasi. That did the trick. My uncle was transported from Kumasi to Accra Medical Center, the one opposite to police headquarters. And thank God my uncle is alive. So we are talking about solutions here. That is one major area we should delve into. I don't have time. Like I'll give a typical case that happened yesterday in my office about a student and how a nurse treated this young girl, first year student. And if it was not God, something drastic could have happened. And so human relation to people who come to a hospital is key. The second thing is that can't we also be intentional? As you mentioned the number 27, specialists in those specialized areas. I just did the calculation. I only used 33 million. And it's like one doctor is attending to 122,222. Can you imagine that? So can't we be intentional as a nation that we need this number of these specialized people in this area so that government can give support, individual can give support so that we train such people to manage such cases. Thank you very much.
Thank you very much. Assistant Headmaster of Achimota School, Mr. Boateng. Thanks a lot. We'll take a last one and then we will get comments. Okay, here you go.
I have to say something. In 1973, I was a senior house officer at Elizabeth Garrett Anderson Hospital for Women and Children. At the time, it was about 120 years old. What impressed me was that I had just come, graduated from Kolebu and gone up there. In Kolebu, at one time, I got stuck on the lift. And the new buildings in Kolebu were only about 3 years old then. But every now and then, there were lifts that broke down or weren't working. In this hospital that was over 100 years old, the lift always worked. The 2 years that I was there was never a time that the lift broke down. Everything worked. Do we have that here? You go to a ward, a toilet flushing thing, the handle comes off, and then it's left. It is not only in the health sector, everywhere else it's the same. And so we need a change of mind, not only in the health sector, but as a people. And also, we cannot expect to have first world healthcare in the third world country. We have to face that. The funds are needed. Dr. Lydia, funds are needed for healthcare. You talked about the Abuja Declaration, that it had been determined that 15% of annual budget, not the thing, was needed. We are only at 7%, and it was over 30%. So the funding is needed, discipline, a culture of maintenance of our resources. I don't think there's any equipment that has never been bought in Kolebu. They come and the next moment they are gone and nobody cares. So we need to think about all these things. Plus we need to take care of our health professionals because they do a job that is not only saving lives but sacrificial as well. And if we don't look after them, we know what happens. They'll go to where they are better appreciated and taken better care of. But we are all Ghanaians. We want Ghana to succeed. So we have to come up with ideas and suggestions to make things work for us. And I'm glad that this is taking place now. I'd like to congratulate the three speakers. I think they all put in very legitimate, and cogent submissions. Thank you very much.
Thank you very much, Dr. Eunice Brook. My name is member of the Council of State, former health minister, and former girls' school prefect, Achimota School. All right, so that sets us up nicely for like we're going to wrap everything up. I'm going to start with Mr. Ofori. Let's keep it brief, 2-3 minutes, way forward.
Thank you. I think my first thing is that we're still not intentional about healthcare.
So get more intentional.
We talk about funding, but you can have the funding and put the money in the wrong places. And I'll be very honest and brutally honest. I think it was a travesty of justice to attempt to build 111 hospitals across the country. I don't know what thinking went into that. In a country where a thermal coagulator for cervical cancer is $1,500 and 3 V8s can put one in every district. And we don't have one in every district. Less than 4% of all women have ever had cervical examination in this country. But it can happen. In 2004, there was one neurologist in this country. They've managed to train 16, with 6 more in training and 3 pediatric neurologists. The ecosystem needs to work. And the policymakers have to understand. I remember I pushed breast cancer and then followed by the rest of the cancers, others pushing it, including companies like Roche, International Health Insurance. And it was accepted and expanded. Later, when people went, and I'll say people went, to put other cancers, cervical, childhood cancers, and prostate cancer, the leading cancer for men. Can you imagine? Parliament threw out childhood cancers and prostate cancer. And they had to lobby to get childhood cancers back. Kenya copied from us. South Africa copied our national health insurance system from us. But Kenya covers all those. Rwanda and Kenya have air ambulance. And our land ambulance, even when it arrives, I'll tell you something, it's not functional because most of the basic equipments in there do not work. So don't be happy when you're called in and the ambulance comes. I mean, I talked to one of the paramedics about why a friend, they didn't attempt to use a defibrillator. He looked at me and laughed and said, Massa, after COVID, none of these things have been serviced. Half the defibrillators don't work. So we need to be intentional about healthcare. I had a harrowing experience where we rushed into a hospital in the evening, and 3 hospitals, 9:30 in the evening, not one doctor had a doctor's pen torch to look down my throat to take out dislodged bones, bones lodged in my throat. Not one doctor, 3 hospitals had a tongue depressor. Yes. And when I mentioned that, don't you have this thing? No,
so,
it's
so
horrible.
we need to be intentional.
You need to be intentional.
All righty. Thank you so much. Let's applaud him. Give him a round of applause. Dr. Johnny Selby, what's your one takeaway from this conversation? One takeaway that will help. Here.
I really think the healthcare professionals in this country should take back their space from the politicians and the wannabe whatever hanging around. Health attracts a lot of external funding. We can do it ourselves, yes, but the external funding is there. So every wannabe wants to be in the health space. The healthcare professionals should take up the mantle, take up their space, and be the ones taking the decisions.
Okay, thank you very much. Back what belongs to you. One of them is here. Dr. Totime, our keynote speaker, what's the takeaway from this conversation?
I told the story from, how I started and where I am now. And I think that the public can look at every part of this story. I think it's about time we looked at scholarships for students, scholarships in medical school, taking care of patients in our schools. I still go back to the issue of money. I think that, yes, money can be thrown at things and maybe may not work. But I think, the students in Achimota School who can be sponsored so that they can learn and become doctors. There are patients in our hospitals whose bills can be paid. And so I would say that, let's still look at the issue of money, looking at it for training, looking at it for looking after patients. And we still haven't spent as much philanthropic money in Ghana as we should. Thank you.
All right, thank you so much. Let's appreciate our keynote speaker and our panelists who will stand now for a photo. Please stand for a photo. Step forward like beauty contestants. Yes, step forward. Where's our photographer? There he is. Yes. There he is. He's over there. Thank you so much. It's as if they decided on the wardrobe before they came here, It's working. It's working. Easy. All right, we'll now call on our OA president to just do a summation of the discussions, and then we'll present the certificates. Yeah.
Thank you very much, Kafui. Accra Kafui Day. Ladies and gentlemen, I'm sure we agree they all deserve a big round of applause. Thank you very much, Accra, Dr. Teddy Totime. Thank you very much, Accra, Dr. Gideon Janselby. Accra, William. I heard them call you Losai from there. William Losai Ofori, thank you very much. So, Accra, I don't know that we could ever have exhausted all the issues in 3 hours, 2 hours, 2 hours and a half. But I think we've begun a conversation. My duty here is to summarize, but Kafi, I'm going to punish you very soon. Before I do that, I just thought I'll share my own, without having to ask a question or be on the panel, my own thoughts. And it's been mentioned a little bit as well. And I'll touch on some of those in the summary. But one thing that I think that, speaking about being intentional, that we all need to be intentional. And I pray this of our health professionals, doctors, nurses, all those in that medical space. Look, I believe that the money is important. And I know that we don't pay our health professionals half as much as they should. But I think one of our biggest problems with the quality of healthcare is our attitude. The example you give, that was given about a doctor who passed, He got there first. He lay there. Nobody said anything to him till somebody recognized he was a doctor. It happens over and over and over again. The nightmare stories that we hear, that most of us have experienced, about nurses who won't give you the time of day until you are almost gone. My wife is here, and the Kingsley House girl too, by the way. There's a particular hospital we swore we wouldn't go to because when she was pregnant with our first child, as she lay in that hospital with malaria, a mother came into the hospital with her son. The mother walked into the hospital alive with her son. Lay in a ward opposite us. Nurses station here, 2 wards there, and we could hear the mother moaning in her ward, and the little child, 4-year-old, 5-year-old, maybe something like that, right? 4-year-old, moving from that ward to the nurses station and tell them, my mother is in pain, please come and take a look. Go back, come back, go back, come back. And we could hear the nurses say, oh, dang, that's what I would. She's in pain. By morning, the woman who walked into the hospital was gone. The woman who walked into the hospital with her 4-year-old son was no more. And all that we needed to do to avert this was for some nurse to just go and check and not assume that she should know. She's in labor, she should know. Yes, it was labor pain, but something was definitely going on. So I think that we just need to be very intentional. Look, I know like I said, we're not paid enough. But if that's your profession, for all of us, once you decide that that's what you want to do, we've got to be able to dig deep and do it. Whilst we deal with other issues, including making sure that they are well paid. But if you go into a hospital and nobody's going to give you nobody's going to mind you until you know a classmate, or until it makes that bad situation significantly worse. So I pray all our health professionals to just take that role a little more seriously, because whilst we are dealing with it, we are frying the big fish. The little fish will kill us. Kita schoolboys. Okay. So, ladies and gentlemen, in terms of summary, we heard from our distinguished keynote speaker and panelists. Dr. Tutume walked us through how he got into the profession and how that has guided. And I'm glad there are 2 living testaments right here. We're not waiting till you pass and then we're going to read a tribute of what it is that you've done for people. So thank you very much for all that you've done and continue to do. You spoke, Dr. Tutume, about losing. Yeah, I think he deserves that. Experienced medical staff through brain drain. You mentioned that it doesn't look like healthcare is a priority for the country because of the fact that we're a young population. You spoke about the fact that we need to look at this more like life care, apart from everything else. You spoke also about it looking like the country is not interested in improving our knowledge of the healthcare challenge, among several other things. Dr. John Selby, you spoke about how we've made strides in routine medical care, but us needing to pay more attention to non-communicable diseases. That we cannot have policies that are only fair to the elite. Healthcare has to be equitable, things that benefit each and every one of us, regardless of who we are and where we are in this country. That we do have great policies, and I think a couple of you, probably each of you touched on that to an extent, where people come into our country, copy, and go and do better. And yet we have the books that are gathering dust. So if we will follow our policies, our battle will be, I don't know about half, but we will win some of those battles. Our institutions are broken down by excessive politicization. We're sacrificing good policies on the altar of political expediency, as we do with many things in this country. And that our biggest issue is priority and letting the technical people run the system and not politicians. Zilos. Accra William Ufori also spoke about us not being intentional enough about healthcare delivery in Ghana. Once again, the policies are great. Execution. Our delivery remains suboptimal due to no self-motivated personnel, and I've spoken about our recognition that we don't pay them enough, and it cuts right across. Frustrated personnel and overburdened facilities. Individuals determining that quality of healthcare in Ghana instead of systems and processes. The individuals are determining instead of our systems and processes. That we do indeed have a semblance of death care. That a good health system requires leadership, governance, and of course accountability. You spoke about the statistics and how we are not doing well in our healthcare delivery system. And of course, the question about how do we actualize these policies to transform outcomes. Good questions from the floor, but I think ultimately we will agree that this is, once again, just the beginning. How do we make these things happen? Are we going to continue to talk? What happens after Achimota speaks? We on our part will put the communique together. We will share it with the Ministry of Education, Ministry of Health. For instance, once again, we invited the powers that be. They are not here. We hope that when we share that document, it will be given some attention. But I don't know. Yesterday, I was in a conversation with a group of friends. We were talking about, aren't we tired of just talking? Aren't we tired of just talking? Maybe Ghanaians, we've gotten to a point where we must act. I'm not sure what acting looks like. But let's do something beyond talk. So I thank you very much once again to our keynote speaker and our panelists. I thank you very much to all of you here in this auditorium and online for your contributions to this topic. Let the actions begin. Thank you very much. I'm going to call on the chairman of the planning committee, Accra, Ernest Kwesiokun, to come up and say thank you properly to our keynote speaker and our panelists, and then we'll take it from there. Accra. Oh, and our moderator, of course.
Thank you very much, Joel. Good evening, everybody. I think it's been quite a good evening in terms of discussing the topic we put up. When we started, I was a little bit worried about the topic, whether we were actually addressing it. But at the end of the day, it's been very serious talk. But a lot of doom and gloom. When I take my own survey, healthcare or death care, I think that the arrow is oscillating a little more to the right than to the left. I don't know if you agree with me, but that's my view. However, let me say that as chairman of Achimota Speaks, our job is to get people to talk about what we want them to do about the topic we put up. And I say that our people did a very good job. Thank you very much. Before I thank them properly, this was just a prelude. I have a few things other to say. Achimota Speaks is part of OAA's preparation for 2027. Those of you who are here know what 2027 is all about. That is when Achimota turns 100. As the chairman, as President Owe said before, we started this when Achimota turned 90. And we've kept it going, waiting for 2027, when we will do the full Achimota Speaks once a month. So, get ready, because next year we'll do 2 Achimota Speaks ready for 2027. It's a lot of work. I'll let you know who have been doing the work very soon. But let me say that organizing this Achimota Speaks sessions have been quite a difficult task. First of all, choosing the relevant topic, which will excite everybody, is very tough. Then finding people to speak. The president says Ghanaians like talking, but not all of them want to come up here to come and speak. We've had a hard time getting people to come and speak. So these guys, that's why I trust them. They've done very well. And so get ready for a few more, especially 2027. We have been able to do it because a lot of hard work by certain people. But the money, as they've been talking about, is important. We struggled to get sponsorship for this occasion. But we did get a little. First of all, we got this hall. Shippers Authority, we thank you very much for giving us this hall. I have to thank one person particularly, Akura Ben is not here. I don't know where she is. She just went out. Right. She was very instrumental in giving us this hall and actually paying for it. We also got a little bit of money from Accra, Daniel Appiah Kisi of Das Pharma. MTN did their bit and gave us some money. And then we got City FM, Channel 1 TV, Joy News, Star FM, and GH1 TV, who gave us space on their channels to be able to talk about Achimota Speaks and to publicize the fact that we're going to be here this evening. We thank them very much. Personal thanks, I think the students of Achimota School, we thank you very much for coming. I hope you've learned something. I hope you're all looking to become doctors, real ones. So thanks for coming, and thanks to the school, especially the choir, who've been very good to us. One announcement I have to make, which is not Achimota Speaks. I did say that we're working towards 2027. There are many other committees doing various things. One of them is going to carry out plays, operas, all towards 2027 and during 2027. They are showing the play called The Blinkards this Saturday. So if you are interested, there are tickets in the foyer that you can buy so you can attend that hilarious play by Kobnasechi. It is going to be held in the Assembly Hall, old or new? Old Assembly Hall in Achimota on Saturday starting, there are 2 shows, isn't it? One at 4 and one at 8 p.m. So those of you interested, please take note and be there. It will be very good if I can show you. The committee is made up of a few members, and since this is the last Achimota session for this year. We had one in March, we've had the November, and it's the last for this year until next year. So get ready, but let me tell you who've been working on it. They're all Accras. Eunice Kwakupom, who you all know as the Secretary of the OA. Anne-Marie Danso has been indefatigable in getting things sorted. She's out there somewhere. Joel Nete, who's the president of the OA, is part of the team. We have Osei Round Ajiman, but he's not here tonight. Selassie Achianu, Tony Ajete Ajay, assigned master at Achimota School, and the important person, Clarence Amate. Should I say honorable? Clarence Amate is in the team. Elizabeth Irene Beatty is our prayer warrior, and she'll come back to pray. Leziki Ni Ade, our youngest man on the team. So, of course, we send him to get the coffee and stuff like that. And then there's Yaobene Amponsa. And, of course, myself. So we have worked hard to put this together. We're very fortunate to have our 3 speakers for tonight. And my last job is to say thanks by giving them a certificate and a plaque, which they can hang wherever they like. Especially when you're talking about NHIS and so on, put the plaque there so they know that. So the first plaque will go to the main speaker, Dr. Teddy Totime. And I'd like to call on Akura Harold Eseku, who is the chairman of the Achimota at 100 committee. There we go. Normally to be ladies first, but I thought I should do the main speaker first. So now we can go back to ladies. So I'll ask you to stay and give a plaque to Accra Lydia Janice Selby as panelist. Lydia, the camera is there. Uh-huh. And one to somebody who has been very instrumental in helping us to put this together. Mr. William Ofori. He wants me to call his nickname, but and of course, one person who has guided this whole show from beginning to end, and I must say he has done a very good job in keeping us all glued to our seats with our eyes wide open, our ears even more open to listen to what the experts have to say. So, moderator, Kafuide, for a good job. Thank you. But of course, I cannot walk off the stage without saying thank you to all of you who came to Grace occasion. I know, as I said, it's been doom and gloom, but there have been bright spots along the way. So I hope you're going home with something you have learned from tonight. We also hope that the powers that be will actually hear what has been said tonight and some result may come from it. I'm saying result. The panel will say outcomes. So let me thank you all very much for your participation. Finish. For your participation. Now, I'd like to bring our moderator back to continue to the end of the program, which will be very soon. Yes, so please stay and...
Thank you very much, Akra Okun, for presenting the certificates and thanking our people. Just before the anthem and by the school choir, this was just a question from Daniel Allen from OAA 91. He says, where does prevention education come in? There's talk about getting dialysis machines, but no one is talking about risk prevention. Dr. Tetima, you talked about everything, but not prevention. If we can increase prevention, we can decrease hospital visits. So that's Daniel, who is just thinking about prevention. So that was just a contribution. Thank you so much. We will now have the national anthem, and to be performed by us with musical backing from the Achimota School Choir. May we all stand for the anthem, please. Still standing, I'll invite Accra Elizabeth Arimbeti for the closing prayer.
Shall we close our eyes for a word of prayer, please? Jehovah Rapha, we thank you for an evening of shared insights. We thank you for stirring hearts to speak truth with courage, with wisdom, and also with hope. Father, we remember the dream shared today, and we pray that this dream may be backed by focus and by purpose. We thank you, Lord, that this conversation in some way will lead to transformation of healthcare in our beloved Ghana. Amen.
And still standing, school song from Gambaga to Accra.
All to them that we will teach, so to subjugate
Thank you so much. Safe journey home. God bless. Till another Achimota Speaks comes your way again. Refreshments for sale outside on the corridor.